Hello everyone, welcome to The Voice of Nursing. My name is Adrian Tracy, I am the CEO of ICG Medical. Today, very lucky to be joined by Nicky Lambert, and I just want to make sure I get this right, Director of Teaching and Learning for the Mental Health and Social Work at Middlesex University.
That's right. Yeah.
Welcome, Nicky.
Oh, I feel welcome, thank you very much.
Nicky, tell us how you got into nursing.
Wow, that's a long story. This is my 20th year in nursing, so I do feel like I'm having and have had a very, very lucky long career. I was going to be a history teacher, and then I just had this this feeling it just wasn't for me. I could imagine myself talking about the Industrial Revolution to a lot of people who weren't really listening. And I thought, and I went travelling, and I was in Australia, and people kept saying to me, "Oh, you're a mental health nurse." What do you mean? I came from a family of nurses and the odd doctor, and they're adult focused, and so I had no real interest for me, and it was something I never thought about and never considered. But when the sort of third or fourth person said, "Oh, you're a mental health nurse," I thought I would check into it and find out who these people were I kept accused of belonging to. And when I did, I realised I'd found my people. Absolutely, I'm a mental health nurse through and through, like a stick of rock. Never been happier. I went off and trained just around the corner from here, and I've been a nurse ever since. And proud mental health nurse.
Lovely to hear. Talk us through how you sort of got to the role that you're in today.
Okay, so I trained at King's, which was a lovely experience, so I get to work in all the central London hospitals. Then I went out to work at the Maudsley, so my first job was an intensive care unit at the Maudsley, which was very loud back in the day. Yeah. After that, I went and had some adventures in Australia and travelled. I met lots of people, lots of Irish and English nurses who I'd been travelling with and who I'd also worked with. And so I actually bumped into people who I'd worked with at the Maudsley, which was lovely. But mental health is like that. It's one of the things I think it's so important to have a good reputation, not just because it's the right thing to do, but because you overlap all the time. You meet people all the time that you've had different touch points in your career with. And I have to say, it's really lovely. It's a great experience. And then I came back and I worked briefly, well, not briefly, I wanted to be in London, but then I realised that I was sort of repeating myself, so I went down to work in Brighton, and I set up a women's ward there and worked on a men's ward afterwards. I became a practice development nurse, and I had so much encouragement from senior nurses around me, and I'd never thought of sort of pursuing an academic career. I was, an okay student, and I loved learning, loved reading, but I never really thought of myself as smart enough to be an academic, enough to say, if that's on anyone's mind, trust me, you can do it. It's a really interesting job. So I started to do practice development, very excited by the possibility of not just influencing my own practice, then when I was a ward manager, influencing how a ward was shaped, then when I was a practice development nurse, looking at how we can do things much better sort of across a trust. And then I went off to work for the University of the West of England, where I wanted to be part of teaching big cohorts of students. So all the time it's this idea about driving things forward, making things better. All the time I think I've been learning on that journey, and nursing is one of the really amazing careers that the more you give to it, the more it gives back to you in terms of life experience, understanding yourself and other people a bit more. And then I got to a stage when I'd done a lot of things in terms of mental health teaching, and I wanted very much to do more research. So I'd done my practice, I'd done my teaching, so I've come back now into London and looking at research, and I work very happily as an associate professor up at Middlesex University. With a sort of remit that spans mental health and social work, which is just lovely, and I work very much in partnership with my adult and child nursing colleagues as well. We do a lot of work with Camden Islington Trust and Barnet Enfield and Haringey as well, and also I've got a lot of links with voluntary services, and I do a lot of my own personal sort of practice in that area, so I feel very, very fortunate.
Very humble as well. Obviously mental health, very, very big topic at the moment. It's
a growth industry. This is a great time to join us.
Unfortunately so. Yeah. But talk us through some of the challenges you're seeing around mental health, and some of the things you see on the horizon at the moment or in the future.
I suppose we could call them crisitunities, so both crisis and opportunities. Yeah. So some of the things that are happening at the moment is we are still not sort of cracking the back of sorting out physical health for people with mental health issues. So we still have an early death rate of 15 to 20 years for people with serious mental illnesses, which is not acceptable. It's not acceptable to be surrounded by nurses and doctors and be in a health service that's not able to support you to live as well and happy as the person next door to you. So that's a real issue that we are still working on, and I think a shortage of nurses generally is a big issue for everybody. It's a global issue, it's not just for us. We're very lucky to be part of Capital Nurse, and obviously it's a fantastic programme here as well. So looking at the fact that I don't think we've talked ourselves up enough. I don't think population knows what we do. You know, we have this issue all the time, you still revisit this, should nurses have degrees? Nobody asks if an engineer should have a degree. You know, I can't imagine getting on a bridge that by someone who has, built by somebody who hasn't had sort of a higher education. So why on earth would you allow somebody to give you medication or to advise you in a life or death situation who hasn't got that extra study? That's a very strange subject. So a big issue for nursing, I think, is about opening ourselves up to be more understood by the general public. So what do we do? The other issues I think that we're looking at the moment is the fact that we're not very representative sometimes. You know, we wonder why we don't have enough nurses, and we hardly look at half the population. So a lot of men just don't feel that nursing is for them, which is a real pity. I mean, in mental health we're very lucky, we're about 30% male. Adult nurses tend to run about 10 to 11% male, which is ridiculous when you think about it. And when they do come in, they either go into management straight away and straight up the ladder, or which is a job for another day, or they'll go into intensive care or accident emergency. So there's something around sort of spreading out the skills of those populations. The other issues that we have are that people from black and minority ethnic backgrounds don't always get the same positivity and opportunity that their other colleagues get. So if you look at the pyramid of staff in the NHS, the higher you go, the whiter it gets. And that's not what London looks like. That's not necessarily what the rest of the UK looks like. It's not right. That's another issue that we need to look at in terms of how we work. More issues that we have, which are real opportunities, I think, to do better, about being more egalitarian. So in mental health, we're trying to move a lot more towards co-production, so sharing out the power that we have had and hoarded a little bit, to make sure that we value expertise by experience in the same way that we think about our expertise by book learning or expertise by professional time spent on wards or in community services. So that's something to think about. The things that really excite me, the fact that we're now thinking more about public health and mental health being part of well-being. So on top of that, this idea that, you know, really getting to grips with things like loneliness. I was a little bit depressed, and if you saw the story about people developing a pill for loneliness, which is not really
solution.
No. So a pill to forget that you are lonely, or a pill to make you not register your human emotions, is not a solution at all. We need to be thinking about how we work in communities to bring ourselves together and to connect up and to value people. I get very disturbed by the thought that some people are considered disposable, which is not a way for us to move forward, I think, together as people.
It's a lack of care, isn't it?
Yeah, so there's loads of things going on at the minute, and I think we are in, as you rightly say, this period of turmoil, but steady hand, common sense. There are things that you can do in periods of turmoil that you wouldn't get away with in periods where everything's settled and you've got a very fixed hierarchy. So this is a time for people who have exciting, innovative ideas to come forward. Social media is a great democratiser. If you want to connect up, it's the place to put ideas, it's the place to find like-minded people.
Yeah.
You know, your community of practice is not just the person you're with, it's all the people that you can reach.
Yeah, was it the Academy of NHS Fab stuff? You know, we rate those guys highly, we know them well, but they're always sharing best practice, aren't they, across the country? And
that's what's really exciting. Also, things like Starwards. So don't think I'm saying Star Wars. I'm saying Starwards as in, the work done by Jeff Brennan and his group, which is really exciting and innovative. And when I was a baby nurse, it was one of the things that I really was passionate about when we started to look at recovery practice and this idea of supporting people to live well and happily. And the best thing we can do is get out of their way sometimes. And that, I think, really turned my understanding of how different ways that you can help people on its head. I was never much for the sort of biomedical model by itself, but I think very much having service user partnership was something that it was both a relief, like it made me much freer in my practice, but it also it just sits better with my sort of ethics and morals.
And talk us through. Obviously, we've had RGNs before talk about their type of job. You can give us an idea what does a mental health nurse do? And I know some, not to make it basic, but just more to give us an idea of what the differences are, because we've had lots of RGNs on, and various different people who've got different skill sets. It'd be really interesting from a mental health. What does a mental health nurse do?
A mental health nurse likes people. That's the main.
Like people.
No, not like a mental health nurse does. Okay. Mental health is a growth industry, as I've said, but it's absolutely across all of society. So as a mental health nurse, you might be working with children and young people in schools, looking at anti-bullying campaigns. You might be working in a CAMS, which is a child and adolescent mental health unit, so working with people who are starting to become unwell and making sure that they stay in mainstream education for as long as possible, and keeping that quality of life going, supporting families. It might be that you're working in GP surgeries with young mums who've just had babies and having perinatal mental health issues. It's very common in our society and we don't talk about it enough. It might be that you're working alongside school nurses to work with young people who might have tried to cope with the pressure that so many people are under by using something like self-injury or something like that. You might be working with people who've had a brush with the law, as we would call it. So someone who's been maybe in prison services or has been referred through the courts, you might have support there. You might be working with people who have drug and alcohol issues, any kind of substance issues. You might be working as a community nurse, going out and helping sort of an older person with the real complexity of life, from things like managing a leg ulcer at the same time as managing diabetes, at the same time as managing being a carer for someone with dementia, which can be very, very stressful. A lot of carers experience mental distress themselves, unsurprisingly, disrupted sleep, lots of pressure. You might be working in an intensive care unit where people have been referred and they're extremely unwell. You might be working in recovery-based services, helping people get back on their feet and go back to work. You could be working in a thing we call IAPT, which is basically like talking therapies. So for people who have a low mood or anxiety, you might be giving telephone support to somebody who's like 5 minutes to come out in their lunch break and access your service. You could be working as a researcher, an educator. There really is no end to the things that you can do as a mental health nurse. Anywhere you have people who are struggling with life's problems, you have mental health nurses there. It's absolutely so much choice, so much option.
Like one of the things that we always talk about here, or comes up quite a lot, is the mental health of the actual nurses. What's being done for mental health nurses, because they're obviously at the forefront of it, trying to help everyone else. I
think the resilience issue is a very interesting one. And there's a lot to be said about it. In terms of staff well-being, I can't think of a single large-scale employer who isn't having to tackle this issue right now, in terms of the most common issues being sort of depression and anxiety, but certainly all the other pressures that workers are experiencing. So work has been done really interestingly by Mind. So the mental health charity has done some work looking at how to support people who are working as frontline staff in accident emergency units, because it's task focused, and then you're moving on before you've had a chance maybe to process some of the real emotional labour that you've had. So what I mean by that is, if you are on a building site lifting bricks, you'd expect to have sort of pressure in your back, you'd expect to feel that at the end of the day, whereas I think sometimes people will be very close to people who are in pain or who are very angry or very frightened, and that does make a difference to how you feel. But if you haven't had a chance to maybe reflect on that with colleagues, have a signing off period at the end, we've drawn a boundary around that type of work, and then going home to your family or friends or to do something creative, something like that, it can disrupt your sleep, it can make you very anxious, and there is a lot to be done in terms of improving that. But I think one of the best things you can do is make sure you're working with colleagues who you like, who you trust, and who support you, and there's enough of you. That's the first key, I think. Make sure that you're skilled yourself, make sure that your employer is following recommendations. I personally, and this is a personal thing, would say join a trades union and make sure that you protect yourself that way, belt and braces. And then the other thing to think about as well is with resilience, make sure that resilience is not being used to critique you. So suppose you are under pressure, and you're under pressure because the system around you is not functioning, that's not you. And I think one of the real issues with resilience is people pointing to the one person in a team who's taking the brunt of the structural issues and saying that person is not resilient. And that's not fair, it's not true, and it's not a clear understanding of resilience, because the things that you can do to support resilience are to allow people to have choice, feel self-efficacy, that they can make a difference, to ask for help when they need it without being singled out. And when that doesn't happen, that's when you start to see people going under, I think.
And do you see, you know, obviously you talk about the system. Obviously one of the challenges we talk about is doing the 3/12s. The 3 12-hour shifts in a row, and you're going to get tired. You know, you're going to make mistakes, and
it is a real struggle. And I think one of the issues, I don't want to make this too London-centric, because I think it's a problem for everybody, is if you're a single parent and something like that, you're trying to keep a roof over your head on wages that don't always match up with the living costs around you. And it's very easy, I think, to want to work sort of long shifts so you can fit just that one extra in, that one extra for Christmas presents or a holiday. And that's a real concern. For me, the thing I always found most difficult was working a late and then an early, and then going on nights and flipping back. So swapping between shifts was difficult. But also, we used to, when I first started off work, late Friday, all long day Saturday, Sunday, and then an early on the Monday morning. And it really felt like you'd spent more time sort of in hospital than you had actually out and about. And it was very difficult to switch off. And if you've had a very highly charged shift, you have to get home, then you have to try and calm down, to go to bed, to get up. And there's nothing worse, I think, than lying awake thinking, I've got to be at work in another 4 hours. So there's something to be said about that. Yeah, absolutely. You get better at it. And I think having sort of clear emotional boundaries for yourself, and remembering that it's not all on you. You work with a team because you hand the baton to them, and then when you come in the morning, you take that back. So there's something around, I think, having that experience of having a very close-knit team, a team that's effective, that actually spreads the load to a point where it's manageable.
And I know you do some other work, which I know you want to talk about, with the RCN.
Yeah, I talk about it.
Yeah. And also some of the stuff about ward safety. I know you mentioned to me earlier as well. Be good to hear about it.
Right, so Camden and Islington are doing some amazing work at the minute as a foundation trust on sexual safety for inpatient services in particular, but for all of their services. And one of the things they're doing that's really innovative is they've combined their policy together. So you don't have a policy for service users and a policy for staff. You have a policy for people, and the sort of equality built straight into that from the start, I think is really admirable. And I think what I particularly like about it is, in the past, I think there's been this expectation that if a staff member reports something, that's been dealt with very seriously or taken seriously. If a service user says, this has happened to me, people then investigate it, and it's given a very different message. The fact is, if an issue has happened, it needs looking into. It doesn't matter who reports it. And I'm very impressed by that. And it's a response to the CQC sexual safety in inpatient settings that came out in November. But we're having a lot of policy coming one after another, flying out of the door. So another thing that happened in December, the Women's Mental Health Task Force strategy was released. Obviously we're going to have Women's Day tomorrow, so it feels like a good time to talk about that. It's a really interesting bit of work. It's talking about the kind of gender differences that people present with, and I think what I particularly like about it is that when you change perspective, you're like, how does this service work for a man? How does this service work for a woman? How does it work for somebody who has limited mobility? How does it work for someone who's in employment? How does it work for someone who's got these other experiences? You start to shift your perspective on how your service works, and a service that you think goes, that's fine, when you look at it from somebody else's perspective, you're like, actually, do you know, that's not fine, there's something we can do with that. So in my experience, having worked on a women's ward and then worked on a men's ward and then come back into general, everybody together ward, is that having those perspective changes helps you figure out how you can make things better for everybody. So I think I really welcome that, because when we have we've had this Women's Mental Health Task Force report now, which looks at some of the things we can do differently, and there's a lot in it which will benefit everybody.
The sort of top 3 things that have come out of that? I thought
that were particularly interesting was sort of working in more of a trauma-informed way. So a lot of the people we have come through our doors, and a lot of people I think in society, have experienced either sexual trauma or trauma in their life at some other point. And it's about making sure that when you work with people, you make sure that you don't make that worse. So you can imagine, can't you, if you've had a situation where maybe if you've suffered a sexual assault and then you become unwell and you end up being restrained, how incredibly distressing that is, on top of the horribleness of that experience anyway for everybody, but how much more devastating that's going to be, how much more difficult that might be for you then to make a therapeutic connection to staff after something like that. But there's fantastic work going on in terms of SafeWards, not Starwards this time, SafeWards, which is a website that anyone can look up, looking at how to decrease the levels of aggression and violence in mental health. There's also lots of work around kind of like this kind of being more emotionally alert, more skilled and adept in how we manage trauma and difficulty, which I think is only going to make things better. And that's something I think that we need to sort of bring into all the services, not just mental health.
And what were the other two things that you said?
The trauma-informed care, I think having single-sex accommodation, and that's a far cry. I was talking to some colleagues who were coming from, I won't say where, east of England, in a rural area. You can work that out for yourself. And they were saying how hard it is to manage people who are very, very poorly on an area where it's a 4-bedded room with curtains between them. So people are wandering around, people are taking each other's stuff. There's lots of things that make a place more unsettled than it needs to be, and someone's recovery slower than it needs to be. The other thing is taking sort of sexual safety seriously. So the idea that you could be confined to a ward, a place of safety, and it not be safe is pretty horrifying, and that's something we need to do better at, I think, in all parts of the health service. When you walk on as a professional to a space, it feels very different, I think, than it does to members of the public. I can remember the first time I went onto mental health ward, and I was basically by the wall looking around in horror at all these people who seemed really quite scary, and then I realised I was in the reception. I actually hadn't got onto the ward yet, and these were my colleagues. So there's something about the fact that if you're not ready for this environment, it can look quite scary. And the other thing I would say is, anytime you have a new member of staff or someone visiting, ask them what it felt like, what that space felt like. Did it feel safe? Did it feel therapeutic? Did it feel like a healing space? Because you get blind to it really quickly. When you have the keys and you can go where you want, it is a very different experience than when you're sitting around waiting for someone to help you, or you don't know what's happening. So there's something around, I think, staying in touch with that, with those new eyes. The experience is great, but it blinds you to some stuff that I think having sort of new, younger, fresher eyes around really helps.
And obviously with your role, you've moved into obviously teaching and doing a lot of work from an academia point of view.
Love it.
Tell us how this sort of nursing education has changed over the years, especially in mental health. You know, what does it lack? What would you change? What would you think moving forward we need to do more?
Well, we've got a new curriculum. I won't look at the camera at this point, because anyone who's watching this as a nurse right now is either crying or just finished crying, going through their validation process. And it's a really interesting curriculum that brings physical and mental health a lot closer together. And that's really useful. And what I particularly like about it is that whilst we're all having to skill up around sort of physical health skills to a point, we're all able now to be talking about motivational interviewing, behaviour change, supporting people with depression and anxiety who we haven't been able to get to before. So now I can talk with adult nurses and children's nurses around smoking cessation, around things like breaking bad news, dealing with intense sadness, stuff that I think if you just have a remit that makes you think that this task is important, and you forget actually there's a whole person on the other end of this experience, I think it's going to make us much richer as a profession.
And how are the nurses finding that?
Traumatising. But it's very exciting. So one of the things we're doing, which I think is going to be very exciting, is we're taking a lot from kind of higher education in other areas. So I'm about to start a module called Expansive Learning. And we have all the students together, adult, mental health and child. We sadly don't have any learning disability, which is another thing you can put on your worry list. Worry list. Where are all our learning disability nurses? Why aren't we supporting them to come through? Why don't people want to be learning disability nurses at the moment? And what we're doing is we're looking much more kind of arts and culture, and looking at kind of putting nursing, all the skills, all the technical abilities nurses have, into that very human context. Because people have experienced birth, death, pain throughout human history. And we're going to be having an opportunity to go to the museums that we're so lucky to have free here, and look at some art, have some people in from different backgrounds to talk to us about looking, seeing, understanding what it's like to be in different, to see things from different perspectives. And I think that's really going to enrich people's sort of critical thinking skills. There's nothing more depressing than this idea that, you know, you don't need to be that smart to be a nurse. Well, you need to be a really decent person, I think, and decent people think. And you can be a thinking person and a kind person. It's not you have to pick one. Nobody else is asked to pick. What do you want to be, smart or kind?
Yeah, I think as well how people have nurses sometimes, you're not just a nurse.
Yeah, absolutely. So there's something around this idea about, if we want to have leaders, if we want to have people who revolutionise systems, want to have people who stand up and challenge when a system isn't safe, who innovate, who work in very different ways, because the health issues that we have coming with an ageing population, shrinking budgets, we can't carry on doing what we've done. We have to be doing new things, and we have to have students developing into practitioners who are able to take us forward.
And you do some work with the West Hampstead Women Centre as well. You're a trustee there.
Yeah.
You're very, very, very busy.
Oh no, they are lovely. They're like my favourites. So one of the things that they do, which is fantastic, there's lots of different kind of groups of women use that centre. And I think what's very interesting about it is it's a single-sex area as well. And we often have, I won't say which council, but saying, why can't you just use the community centre? Why can't you just do this? Why can't you just do that? Why can't you just have everything the same as everyone else? So 20 years the centre's been going, and at the start I think it was working with issues around almost like kind of gardening, yoga, these sorts of things. But since we've had the recession, our usage has gone up 400%. And because the first time we looked at it, we thought we'd done the maths wrong. Like, we seemed very busy. And then when we realised we're actually just having so many people coming through the door with really complex issues, hugely complex issues. And what I really admire about the sort of women that use that centre is they're every age, every cultural background, and they are so inspirational. They're really, really strong, people able to sort themselves out and organise themselves. There's a Somali women's group who are fantastic, Irish women's group who've published plays and books of poetry, and I've been working in partnership at the minute with a Southeast Asian women's group. So there's about 20 to 30 women, and I'm sure they won't mind me saying this, who maybe don't always speak openly to health professionals in professional contexts. So they often can be a little bit deferential, so around and not ask questions, and we have this issue all the time. I think one of the things that student nurses particularly understand is that you'll sit next to somebody in a ward round, it's a very formal setting, and the doctor or the chief nurse, whoever's doing it, will say, "Are you happy? Do you understand?" And they'll say yes. You won't even get to the door before the student nurses ask, "What did he mean? Or what did she mean?"
Yeah, then no one's to be seen that they don't know.
Absolutely. So what I think is really interesting about these women is that they speak 4 different languages between them, at least 4, and they sit down as a group and they decide what health issues are of concern to them, and what they want to ask. They decide 5 questions between them, and then they call me. I find them a health professional who'll come in and talk to them. They cook and eat the most amazing food, which is one of the reasons I go. My little Tupperware dish, like, feed me, adopt me even. It's not too late to have a daughter, it's fine. So they talk about whichever issues they want. So they talk about those random things. So they had a session recently on happiness, which one of my colleagues took. They had a session, I taught a session on Parkinson's, and they just really wanted to be clear what the difference is between dementia, Parkinson's, Alzheimer's, what's going on, what's dopamine. And if you've tried to work in a situation of translation, and then imagine trying to explain dopamine to somebody in 4 different languages, you'll understand quite how traumatised I was in that session. It was very noisy. No, but what I really like is they then take that information back, put it into a calendar and give it to all their friends. Okay. And I think what I really like about that is that it's people, ordinary people taking health into their own hands. What do we care about? What do we want to know? And then disseminating it themselves in languages that they speak. And I think that's really impressive. I love being around people like that.
Well, it's helpful, isn't it? They're talking in their own languages as well. They can relate in.
All the time in their own languages at volume. So it is an interesting one.
And I can't believe you've got another job as well. As a co-director for the Centre of Co-Production in Mental Health and Social Care.
Absolutely. So
when do you sleep is going to be my next question.
I sleep well. I sleep with the innocent. I think when you love something, it's not work, is it? To a point. And so I do some work with my very dear colleague, Professor Trish Hafford-Letchfield, giving a call out there. Yep. She's on Twitter as Archway Diva, and she's very inspirational. She's looking at the support for LGBT populations, so lesbian, gay, bisexual, transgender populations in old people's homes. Okay. And that is going to save lives. I mean, when you just work with people and they blow you away. So there's a whole team working on that, not just Trish, but how amazing is that? Because, you know, can you imagine if you've come out and you've lived your whole life, and then you go into a nursing home, particularly if it's run by a sort of religious or an organisation or something that might make you just hesitate to be who you are, and then you have a partner coming in who's pretending to be your brother instead of your partner or your sister. It's just not right. So there's something, I think, really interesting to be done around that. The work that she and I did together, which was very interesting as well, we looked at women ageing without children who haven't got married. And why that's of interest, I think, is partly because there's tons of them and they're kind of unseen, except when you're in certain places. If you want to know who's running your voluntary services, who's joining every choir that's around in the world, who's sort of doing all this kind of like joining up stuff, it's that population, sort of 55 to 75, 80 plus, who don't have children at the moment. So there's something around, I think, the work that they do, the fact that we assume that people's children will look after them. And if you don't have children, that's not going to happen. And also there's something around, I think from my interest in that area myself was coming at it from a mental health perspective, that they can have quite a stigmatised identity. You know, there's lots of very unpleasant, you know, spinster, cat lady, that kind of stuff that we don't say about sort of the Bachelor set, you know. So there's something around how we talk about people and how we consider whether somebody is useful to us or not. You know, how this I was saying about sort of disposable people, this idea that if somebody isn't fulfilling a social function that we can name, then they're not doing anything and they're not necessary, or it's not important, or they're unseen. And one of the things I think that was really interesting in talking to them is they are very active. It's quite hard to get a lot of them to come to the phone or to come to interviews because they're so busy. They're doing everything. And I think looking at how they're preparing for their ageing process, how they're embracing it or scared of it, how they're thinking about our care homes, our care provision, which some of them were very clear that they were not happy about. So, you know, over my dead body will I go into a care home, that kind of stuff. It makes you think a lot about how we provide all our services, from sort of that kind of care and the nursing home stuff, but also how we connect this population up, how we support them in terms of living arrangements. Loads of things are going to change in the next few years.
I've never even thought about that before.
It's education for you, never stops giving.
Every day's
yeah, absolutely. So we're in this really good position at the moment, I think, in terms of all the fresh ideas that are coming out, the churning around in terms of education. We have all the stuff that's come out around social media. There's so many influencers on social media, so many people who are fascinating to catch up with. And I think we're in a very interesting time for that.
And talk us through the work you're doing with the RCN.
Oh yeah, RCN. I do that too.
I've got them on there.
So I really enjoyed working with the RCN. So I'm an old Unison Unite person. So that's who I started working with on things like period dignity. And I've also now moved over to work with the RCN on working around some project on mental health and menopause, which is also very interesting as well. And I think what struck me as surprising about it was the number of my colleagues who are nurses who still find it a bit ooky. Like a bit like, I don't want to talk about that. I was like, if you talk about suicide and loneliness and bereavement and, you know, the real frightening experiences of mental illness that happen sometimes, why on earth can't you cope with periods and menopause? You know, and also, you know, if you're a nursing colleague, even from an adult background, you know, why isn't this stuff being taught more clearly? You know, it happens half the population. It's a life trajectory experience. It's coming for us. Not you, but that's all. So there's something around the fact that we need to be prepared for it. We need to be able to know about medication. We need to be able to know about hormone changes. We need to be able to offer health advice on that. And the other thing around sort of period dignity, which you see everywhere from schools, and kudos to NHS Wales, who I think have just come forward with free sanitary protection for women. The idea that you can maybe, if you're in mental health services, be walking down the street, be sectioned and taken to somewhere where you might not have access to sanitary protection because you're not going to plan something like that. That's appalling. And it came out, weirdly, of a Twitter chat when people were talking about some of the experiences they'd had when they were unexpectedly detained or when they asked for support or help with this issue on mental health wards, and some of the just woeful lack of response. So there was something around the fact that we really needed to think through what's a basic expectation, how can we support dignity and well-being, what can we do next? What can we do better? And I think one of the real key skills of nurses is when somebody brings up a problem, that you can hear it without becoming upset. You know, there's something. If you look at the ways a lot of people respond to critique in society, we have a lot of polarisation, a lot of very high expressed emotion, hostility for anyone who doesn't agree with us 100%. But there is something, I think, about really being able to listen to feedback, see if it's fair or not, and then jump on any problems, sort them out. I think that's a key skill, because we don't get everything right by a long way.
No one does.
And even when it's okay, it can still be brilliant. So.
And looking at your career, if you look back into when you went into the profession, is there anything you'd have changed, or any advice you'd have given yourself if you were going and having a chat to yourself back many moons ago?
It would have been a waste of time.
With your more mature hat on.
Well, waiting for that hat to arrive. Anything that I would say I wouldn't do anything different. I think what I would. Part of me would love to slow it down and have it happen again, even the awful times, because it's been such a privilege, to be around people who have experienced loss or trauma, and they're just the most inspirational, bravest people, and I think it's very difficult when you see sort of people marginalised or mocked in society, when you know what their worth as human beings is. And that's, I think, always been something that sort of kept me coming back. This idea that even just to sit with somebody who's going through something is such a privilege. And then you sort of walk down the street and you see so many people who are queuing to get to work, to a job they don't want, or somebody who's sat on a checkout till who's in a different place. Their body's there, but their mind's far away. And what nursing has always given me is this ability to use my heart and my head and do something useful. Because if I'm not at work, nobody else can be me. Whereas I've worked in jobs outside of nursing, rather unsuccessfully. I was a dreadful waitress, etc., where anyone could have done it. It wouldn't have mattered who pitched up. So there's something around the fact that
it's not commoditised.
Yeah, it gives you a chance to sort of really express yourself in a way that is really actually meaningful and valid. And I think that's been a great gift. So part of me even would like to do the bad days over again, but there will have always been a lot more joy, I would say, in it.
And what do you think the sort of main trends we should be looking out for mental health nursing over 2019, 2020?
I would love to see us get more involved in public mental health and more involved in debate, but for nurses more so. We're the most trusted profession. We always end up with most trusted profession, and we do nothing with it. So I wouldn't say that everyone needs to man the political barricades, etc., like, because everybody's different. But I think when it comes to things like being part of your community, don't underestimate the skills you have as a nurse. You are organised, you are ethical, you are able to prioritise, you are able to assess and make decisions. Nurses are super smart, and more importantly than super smart, they're pragmatic, they're trustworthy.
They're emotionally intelligent as well. We always talk about the soft skills. Like, whoever teaches you the soft skills and how to learn how to deal with a family and things like that.
I do. Yeah, we do.
But some of the nurses have grown up with this experience and talking to the older nurses and going, hey, how did you deal with that situation? Have you seen this before?
That's another thing I love about it.
That's where you're learning.
Absolutely. That kind of, it's not actually a formal apprenticeship, but being surrounded by so many people who impress me. I love that. So I would say this idea about nurses doing things like joining parent-teacher organisations, joining community groups, being a voice for being a trustee, doing all those sorts of things. But I think it really does build community strength. Nurses should be a prized asset for any community.
And would you recommend others to pursue a career in mental health nursing? I know it's a silly question.
Of course I would.
Why?
Everybody says that. And I think that's one of the things we really need to get over is whenever you say I'm a mental health nurse, there's two things people say. They say, are you doing it to me now? I'm like, no, mental health nurse does freebies. When you're on duty, you're on duty. When you're off duty, you're off duty. And the other thing people say is, I couldn't do that. So if you like people, you are interested in people and you want to help, you're halfway there. And there's always this argument that a nurse is born or made, but mental health nurses, I think, are a bit of both. I think you have to have that passion and that interest in other people and a sense of real kind of social justice, more so perhaps than in other areas, although I think it's an ethical issue throughout nursing. But I think as well this idea of just wanting to do something about it. It's a really excellent profession for that, because you could end up doing anything.
It's a wide remit these days, isn't it?
Yeah, absolutely.
Nikki, thank you so much for your time. Is there any message you'd like to pass on to our nurses, mental health or otherwise?
Yeah, thank you. Thank you so much. I love being a nurse, and I very much love being part of a community with you. Thank you.
Nikki, thank you very much. Thank you to all our nurses, doctors, healthcare assistants for looking after us all.
Absolutely.
This is the Voice of Nursing, and we'll catch up with you again soon.